Reporting from ACC 2026 in New Orleans, I'm Ahmad Amin, one of the general cardiology fellows at Mayo Clinic Rochester. And today I have the privilege and honor to interview Dr. John Mandrola. Dr. Mandrola is a cardiologist and cardiac electrophysiologist and widely known for his excellence in clinical trials and evidence-based medicine. Dr. Mandrola, thank you very much for accepting the invitation.
Thank you for having me. It's nice to talk to you.
Of course. So I would like to start my question, and this is about knowledge about evidence-based medicine and also how to do a proper critical appraisal of a clinical trial. How important is it for cardiology fellows? I mean, as a fellow, I have a lot on my plate. I know I should be familiar with all the diagnostic, pathophysiology, pharmacology, you know, all of them. And this is something as an add-on. So how important is that? Second part is, what resources would you recommend for us to kind of becoming familiar? And the third part, which I think is a bit challenging, how confident should I be in trusting my interpretation of a clinical trial in cardiovascular era?
Well, you could write a whole book and have a whole session for a week on those questions. So I'll try and summarize. Okay, first thing is that as fellows, and I remember it, we're so excited to be learning our new procedures, our new treatments, and we're new to this, and we want to learn all these things. For me in EP, it was learning how to do ablation and learning how to do pacemakers. But I think more and more, I would recommend that we take time out from learning the procedures to looking at the evidence underpinning these procedures. Like why? Why do we do certain things that we do? What does the actual evidence show? I think a good example is this beta blocker withdrawal story. We now know that after infarction in normal LV function, we don't have to give beta blockers. But had you studied the seminal trials for that, it would have been obvious that these trials were highly selective. And so I think that it's important to take time to look at the evidence underpinning the things that we do. And it's not exciting, but it's critically important, number one. Number two, I think that critical appraisal should be thought of as a procedure. You have to learn how to do a procedure. You have to learn how to do critical appraisal. You just can't look it up in a book. You can't look it up on ChatGPT. You have to do it. You have to practice it, and make it part of your whole learning process. Don't you think?
I mean, that's a fantastic analogy with ChatGPT and asking for the procedure. Think of going for a temporary pacemaker and asking ChatGPT to give me the 1, 2, 3 to do. So very similar in critical appraisal. That was fantastic.
And then, you know, it would be impossible for me to tell your audience how to do critical appraisal in a 10-minute interview. But I think there are some basic points that come about in critical appraisal. So number one, I always like to start when I approach a study is this study for asking and answering a true question, or is this study designed to sell more product? So science or marketing. And when you're reading the study, you're thinking about that. And I'm not saying that industry-funded trials are bad. They're not bad. I mean, innovation is important, but industry has an important role. They want to sell products, and that is not bad. But we have to, as users of the evidence, consider the guts of the study. Okay, so science or marketing. Second thing is you have to look at the guts of the trial. So in the methods of the trial will be, who are the patients? Who are the patients being enrolled? How did they enroll them? And how many did they screen to enroll? A very famous trial in my field is Castle AF. Castle AF ended up looking at 3,000 patients and randomized some fraction of that. So when you look at screen to enrolled, how selective are these patients? And then you look at the trial procedures. How is it done? So one of the problems with cardiology trials, pragmatic trials, for instance, is that sometimes they're unblinded. Sometimes one group gets more medical attention than the other. The classic one in EP and AFib is EAST-AF. So EAST-AF looked at early rhythm control versus rate control, and it was very favorable for rhythm control. But early rhythm control got like 10 times more interactions with the doctors. It's not nefarious, it's just important. And then you have to look at endpoints. Endpoints. What are the endpoints? Are they soft endpoints like hospitalization for heart failure? Or are they hard endpoints like mortality, CV death, or these kinds of things? And then finally, I think the results. And the two questions with results you're looking at is, are the effect sizes clinically meaningful and statistically robust? So you could have a statistically robust finding that has a 0.1 or 0.2% difference in effect size. And so you want both. You want the effect size of a trial to be clinically meaningful, and you want it to be statistically robust. For instance, the danger shock trial, which was Impella in cardiogenic shock. It was a clinically meaningful reduction in overall death. I think it was like 33%, but the p-value was 0.04. So it wasn't very statistically robust. So these are things to consider when we're looking at trials. But again, you can't just do it one time. It's a process. It's practice.
That was fantastic. Thank you very much. I guess that was the best summary of the how to look at critical appraisal ever. I want to actually ask you now, with everything new that comes to the cardiovascular medicine practice in terms of diagnostics or therapeutics, drugs versus technologies versus methodologies, and when we graduate, what are the 3 or 4 main tips that we should have in mind in terms of how to adopt those technologies?
Yeah, that's a really hard question, but I would say that if you go back to 2019, along with Andrew Foy, Vinay Prasad, and Adam Sifu, we wrote a paper in American Journal of Medicine, which is open access, called The Case for Being a Medical Conservative. And I take a medically conservative approach to adoption of new things. I'm not cynical. I'm not pessimistic. I'm not nihilistic. I love new things. In EP, we have pulse field ablation, we have conduction system pacing, and I've been an early adopter of those things. But adoption of new techniques, new drugs, ought to be evidence-based, and we ought to expect evidence beforehand, before we do these things. And that's hard because there's pushes to do things, but if you look at the CHIP BCIS-3 trial that just came out, which was Impella for high-risk PCI. So let's say you're an interventional cardiologist, you just finished graduation, everybody's doing Impella support during high-risk PCI. But CHIP BCIS-3, a non-industry funded, government-funded study in the UK, shows no benefit and a number needed to harm for CV death of 8. So clear harm. But yet, when you look at the history of Impella use, we've been doing it for 15 years. Hundreds of thousands of patients have been treated this way. But had we insisted on evidence beforehand, then none of this would have happened.
This was great.
You also asked me about resources.
Yes, please.
Can I plug some?
Of course.
Okay, so of course you know that I have the This Week in Cardiology podcast with Medscape. But also along with Andrew Foy and Mohamed Rouzier, Andrew's in Delaware and Mohamed Rouzier is up in Chicago. We had this idea that we would write a book and we would have 2-page summaries of every seminal trial in cardiology, going back to ISIS and Gusto and GC and all of the old trials, and we would write this book. But then what we decided is that we would write it open on Substack. So CV trials at Substack. And on CV trials, we do 1 to 2 page summaries of the seminal trials, and it's 95% of it is open and free. And so you can take a look at that. And we've just finished the heart failure trials, but we had the interventional trials, heart failure trials. We'll have EP trials, and eventually we'll finish and we'll try and get the book published so that people can open up a resource and look. That's why we do ACE inhibitors in heart failure.
That is fantastic. A very good news for all of us, and I'm hoping that you'll talk about it in the This Week in Cardiology podcast very soon. So, with that, I just want to thank you again, Dr. Mandrola. This was a great learning for all of us, and thank you for your time and watching us. And for more videos like this, please visit the site youtube.com/fits on the go. And now the summary. Sure. So, reporting from ACC 2026, and I have the privilege of interviewing Dr. John Mandrola, who is widely known for his expertise in clinical trial and critical appraisal of cardiovascular clinical trials. I just want to know your recommendation for cardiology fellows in training about how they should think about evidence-based medicine, how they should develop the mindset of a critical appraisal approach to cardiovascular trials, and what resources they might have to learn more.
Excellent. I'll start by saying what separates doctors from palm readers is the use of evidence. So the use of evidence is critically important, but it's like a procedure, and you have to train to do it, and you have to learn the tricks and practice it.
Love it. Thank you so much.